talk about the increasing global burden of HPV cancers and their prevention. Now, some of what I say will probably be fairly well known to many of you, but to try and put it in the context of what I'm going to talk about today is important. So, if you look at this world map of cervical cancer from Lothian, WHO and IARC, then you can see that the incidence of cervical cancer in different parts of the world varies enormously. The red bits are the highest incidence, and just look at Africa and bits of South America. And that's part of what we want to talk about today. But it's going to be about a world of contrasts. A contrast between Scotland, where we've got really good cervical screening, with very efficient processes of call and recall to ensure that women can come. And we've got free immunisation to all schoolgirls aged 12 to 13 in a national programme. And I want to contrast it with Malawi, where despite a government policy on screening, there is very limited screening and almost no treatment, which actually you could argue makes screening unethical. There's a lack of record keeping and very poor follow-up. And although the first HPV vaccine demonstration projects have just been initiated this year, there is no access. So worldwide, it's the second leading cause of cancer death in women, in young women. Oh, sorry for the repetition there. Affecting both young and economically active women. And I think that's the most important thing to remember, that very often the women in their 30s and 40s in developing countries are actually the breadwinners. They're the ones who do all the tilling and the providing. And 83% of these cancers are in resource-constrained countries. You can see right at the top of the ring there, this is East Africa. I can't separate it out into Malawi separately because the data's not there. It's not good enough. But it is at the head of the spiral. But you need to know a little bit about the cause of cervical cancer. And the main cause is human papillomavirus, of which there are at least 150 different kinds. 30 or so affects the genital area. And some of these numbers you may have come across in various things. For example, HPV 6 and 11 cause genital warts, the most common sexually transmitted infection. Type 16 is the most common type associated with cancers, and it doesn't matter what study has been done where in the world. 16 always comes out as the most common. Other types vary from country to country as to what's in second place, but 16 is always the most common. And there are 15 types which have a greater oncogenic potential, and they're sometimes called high-risk HPV. By the way, that, just if I could go back, the background of this, sorry. This background, those are papilloma particles from an electron micrograph I took in 1969 of the wart virus particles from a common wart. But HPV looks the same wherever HPV life cycle is completed, which is not consistent across all kinds of infections, but nevertheless. And I really want you to remember that image, because this is a full infectious particle. That's an empty one, that's lost its nucleic acid. That's a non-infectious particle. And that's quite important when we look at vaccines. This is the phylogenetic tree, which is, as you can see, is very complicated indeed. And that's because papillomaviruses exist in all vertebrate species and have different relationships, obviously, but on the whole, they live happily with their host. They're not there to cause problems. And all the genital types are in this bit at the top, namely in the alpha genus. And the top 10 types there, 16 and 18, and then there's a group in their 30s and 40s, and then a group in the 50s. And that gives you the sort of top 10. So having said 16 was always the most common, the other ones sort of mix around depending on what study you do where. I like to use a traffic light system to try and explain what's happening with HPV infection. About 80% of sexually active adults, men and women, will at some time experience an HPV infection. And most of these will clear spontaneously, roughly 30% in the first 6 to 12 months. It's reckoned somewhere 80 to 90% over about 2 years. There are some that persist for a very long time, but most will clear. Most of them...
Is there a difference between the different types, how long they last? Does a 16 go more quickly? Will you discuss that?
I won't discuss it to a very great extent. It's a difficult one to answer. There are some that progress more quickly, like 16,
yeah.
But in terms of actual duration of infection, we clear the low-risk ones more quickly, but within the high-risk ones, I don't think anyone could give you a really definitive difference in length or duration of infection. So most infections occur shortly after sexual debut. So we do call it a sexually transmitted infection, but it's not only sexually transmitted. And that's an important message to get through to people. For instance, children can pick up HPV in the genital area. We don't really know where it's coming from. It may be that they've shared a towel, they've shared a bath. Most children do that with their parents at some point. But even some of the family studies don't show an exact correlation. The incidence, would you believe it, here in the UK, where we've done quite good prevalence work, is approaching 50% of girls aged 20 to 24. We don't have the equivalent in boys, but we've done here in Edinburgh, we've done a little bit in teenagers with urine samples, and it's still a sizable percentage will be HPV positive. And as I said, most regressive, most infections clear, and more importantly, low-grade disease also clears spontaneously. High-grade disease requires treatment. And then about 99% of cervical cancers are associated with these high-risk types. So, and nearly all of it is 16 and 18. Now, anyone who works in virology or in infection studies of any kind will recognize this kind of curve, because it's exactly the same, it's just it's protracted in terms of the time scale. So we've got infection which clears, particularly with the low-risk types. It's a smart word. So I was just really going to point out this time scale. Pre-cancers, lupus says 25 years. Well, that's quite long. Some of the pre-cancers come up before that, but nevertheless, it's a very long time scale. That's why screening works, because you've actually got a lot of years in which to pick up the precursor lesions. So here's the natural history of HPV infection. Start all in the cervix. A normal infection, about 80% will clear. 10 to 20% might progress to something that's visible, just like a cytopathic effect in virology, that you see it on the cells. Most of all of this because then you get other complications, whether it's genetic instability, immortalization of the cells, interactions with cellular genes, and all of these are associated, these other factors here tend to promote this kind of pattern of progression. So I said that we had two really good interventions in the UK, and if you take cervical screening, in Scotland we started using liquid-based cytology nearly 10 years ago. In fact, in Edinburgh, more than 10 years ago. In England, it took until just a couple of years ago before they'd converted the whole country. So we've got loads and loads of experience of actually using, LBC means that you take a brush sample, put it into a pot of fluid, send the pot of fluid to the lab makes a monolayer smear. So the cells are well distributed, much easier to read, and there's sample left over for other things. Much better than a wooden spatula being smeared across a glass slide full of mucus and red cells, difficult to do anything else with it too. So what about the pros and cons of our screening system as it exists? Population-based, that's really important. Very sophisticated call and recall system. In Scotland, we do it almost in a paperless way. The central SCRS, the Scottish Cervical cytology call and recall system, actually generates the letters for GPs to send out, it does it on the basis of a girl's or a woman's birth date. So they're looking at the annual cohorts every time. 3 to 5 year repeat, huge investment in national quality assurance, giving consistency across the whole country. So most of the world that does cytology is pretty envious of what we have. Nevertheless, even here, sensitivity is quite variable and perhaps reaches 70% for the detection of high-grade disease. The reading is subjective, like I have to say quite a lot of anything that you do under a microscope, and it's extremely staff and resource intensive. And then finally, and this is a recent development, there's a shortage of cytoscreeners anyway, and of people wanting to go into cytology. Few people are entering the profession, so something's got to give. Well, it will be able to give because we have vaccine as well. There are 2 vaccines available at the moment, Cervix, which is produced by GSK, and Gardasil from Sanofi Pasteur. Now, you see the image up here. You see how like empty particles from that old electron microscope, micrograph these look. Well, that's because they produce in an expression, Papillomavirus expression system, or a yeast expression system for the Gardasil. They produce virus-like particles. The coat protein of the virus actually self-assembles into a particle. And our UK vaccine uptake figures are quite amazing and are being sustained at a high level. So if you look here across the 4 parts of the UK, you can see that they've hit the 80% that the government wanted to assure that they would reach 80% to ensure cost effectiveness, because it is a very expensive 3-dose vaccine. Scotland, I'm pleased to say, is the best, and that has been sustained. And you can see that actually it's not just getting the first dose, it's getting all 3 that we're reaching 90%. And that's really important and good news for the future. Just a little bit more here, just to show that this is sustained. And you can see here, because we take, these are the years in which they were given the vaccine. And it also shows the importance of record keeping. Because although we didn't hit the 90% by the end of the school year, this is a vaccine that's 0, 1 to 2 months, and 6 months. Think of holidays, exams, absences. It's extremely difficult to fit that into the school year. And therefore, you pick some up the next year for their 3rd dose, getting that figure over 90%. As a consequence, we can look at birth cohorts and know that those girls born from 1995 are 90% protected against 16 and 18, the 2 types in the vaccine, and any others that are so closely related there might be cross-protection, and that's an ongoing science. The exciting results from Scotland because Scotland set up a surveillance programme which lasts 12 years and goes on, the testing goes on in the reference lab here, is that in 2011, when about 50% of those entering screening at age 20 had had 3 doses, we were already showing a statistically significant reduction in type 16. And interestingly, in type 53. Okay, so was that because of its relationship to 16, or was it because, in fact, there were relatively small numbers at that time and it would change over time? By this year, 70% have been vaccinated of those entering. And now we've got 5 types are significantly reduced. But there are only 2 types in the vaccine. So there is cross protection. These girls all got Cervix. Sadly, in my view, and this is personal, the government changed to Gardasil a year ago. And I think that was too quick to see if this cross protection with different types was really going to be significant. Nevertheless, this is fantastic, and nowhere else in the world can show this yet. Not only that, but if you look at the cytology and histology from those coming into screening, not only is there a little bit of reduction in low-grade disease, which, as you can see, is increasing as in general, but there's still a reduction if you've had 3 doses of vaccine. There's a huge reduction in the high-grade disease, the 16 and 18 and closely related types. Cytology is one level, more subjective, but it's reflected in the histology as well. The CIN1 level is significantly reduced, and the CIN2, 3 also reduced.
We were vaccinating 12 and 13-year-old girls. High-grade cancer occurs in 30-year-olds.
Okay, there was a catch-up, I didn't mention that, I'm sorry. There was a catch-up campaign. Actually, one of the first slides did show the older girls, so up to age 18.
But that's also not true, because communities, we get lots of samples from 20 to 23-year-olds with SIN3.
We do.
But just the
There's
graph
no
beginning to show
cancer.
the high-grade cancer was...
There's no cancer in that.
Okay.
We haven't looked at cancers, because you're right that the cancers aren't. But if you think back to that natural history slide,
Yeah.
these might regress spontaneously anyway.
Yeah.
These don't.
Yeah.
So in a way, this is the most important result of them all. And there is plenty of high-grade disease in women in their early 20s. And the girls from catch-up, so aged 18, 17 and 18, or 17 when they were vaccinated in 2008,
Right.
are now 22. Okay, I jump to this beautiful place. This is Malawi, this is Nkoma Mountain, and I've had the privilege to be there twice this year. Where, as I mentioned, cervical cancer is the commonest cancer in Malawi. And actually, the bullet point below, the Ministry of Health even in Malawi reckons that if nothing is done, the number of cases of cervical cancer will increase by 60% by 2025. Staggering and disastrous. And indeed what we are tending to say is there has been quite good reaction to the Millennium Development Goal of reducing maternal mortality, only for those women to die 10 years later from cervical cancer. So, with colleagues, we've developed a sustainable, we hope sustainable, program of cervical screening using VIA, which is a different kind of screening, and HPV testing in this rural area of Nkoma, not very far from the Norway. We got Scottish Government funding, and we are putting it together a whole lot of different components to provide a new kind of service for Malawi. The Scottish group here got Christine Campbell from Centre for Public Health Sciences, then from Gynecology here in the Royal, Graham Walker and Hilary Brown, and Liz Grant and Isabel Bruce gave us some support. And the Nkoma team has been unbelievably supportive. The medical director Rainier Tierhauer is a South African. The Deputy Medical Director is an American, but we have Malawians running it. Nakoma is a 100-year-old, originally mission hospital, but it now has a service level agreement with the government to serve the regional population of about over 300,000 people. And you can see on the map it's just about there. So our project is to try and reduce the burden and the mortality by upskilling VIA, because the government guidelines in Malawi were for VIA anyway, which stands for Visual Inspection Acetic Acid. But we need to sensitise the healthcare professionals and the population, first of all, so they understand the value of cervical screening. We also need to provide some kind of training in treatment, and not just the training, as has turned out in practice, but actually provide means of carrying out training. And the HPV is more the research end of saying, can we use this as a triage to prioritise women for VIA? Because here we've got a completely unscreened population and the numbers could go through the roof, as I'll show you. We're also actually interacting with the colleges of nursing through a VSO, nurse tutor scheme, to try and develop curriculum models, and with the government to assess what best services can be provided at the end of this project. So what about screening? Well, think what screening is all about. It's really to identify early disease or the precursors of disease, and it's only valuable if it can be applied to populations, even though the benefit may come to individual women as well, or people. There are international criteria for screening, which you can see with that web link to WHO, to try and ensure access to everyone, quality assurance, good management, and ensuring confidentiality and respect for the patient. That's quite hard to achieve in some African settings, but it's really important to us. Now, the smears as we have are just inappropriate. There are no cytologists. There are almost no pathologists in Malawi. So you've got to have something different. So VIA is what they recommended from 2004, nearly 10 years ago, and yet have still not been able to get it in place. And the HPV is being suggested increasingly by WHO and IARC, the International Agency for Research in Cancer, as a way of dealing with some of this screening. So what are the challenges? Well, the limited awareness and the knowledge about cervical screening has meant that we've had to do a huge amount of sensitization, which will carry on for the 3 years of the project. So here we've got women who are attending family planning and being told about the value of cervical screening and being encouraged to come along to the VIA clinics. Here we've got people, not just the women, but men too, in the HIV clinics, because they've got to come along for their ART every few months, and they have ART clinics every day. So there's a huge population base there. But out in the villages, in this rural community, that too is important, to be telling people a lot about cervical screening, because the ignorance level is high. And therefore, when you are ignorant, it makes people afraid. And something that isn't really a problem here, a woman needs to get permission from her husband to even go along to hospital or a clinic to have any intervention. And there's an issue about suspected pregnancy, particularly when people have got very erratic cycles anyway, so they don't really know early enough. So what is VIA? Couldn't be much simpler. You place a vinegar-soaked cotton wool ball on the cervix for 60 seconds. We use acetic acid in this country. Vinegar costs about 50p a bottle. In Malawi, clinics were having difficulty getting vinegar. You put it on the cervix, leave it for 60 seconds, and when you take it off, if there is an abnormality, it looks densely white. So it's cheap, it's non-invasive, can be executed in low-tech facilities, you get instant results, and can also be used in a see and treat. In other words, if you see the acetowhite, can you treat immediately? However, the results are dependent on examiner interpretation, and that links very much to training issues. Because one of the reasons that VIA has not been as successful in Africa as it should have been is that actually people become de-skilled extremely quickly. There needs to be constant renewal of what to look for, so that they don't treat lesions that are too big to be treated and actually are early cancers that would need something different, and that they don't miss early lesions because these women might not come back, because follow-up is an issue. So, the current policy position in Malawi, if you're VIA negative and HIV negative, 5-year screening. If you're HIV positive and no screening. If you're VIA positive result, treatment depends on the stage of disease. That's in theory. None of it happening on the ground to any extent. And then the treatment, what they recommend at the moment is cryotherapy, which I'll come on to in a minute. For the early cancers, they can offer simple hysterectomies, but that's about the level of the surgical skills available. And for advanced cancers, there's palliative care. And by palliative care, I mean minimal palliative care. The problem is that most women with advanced cancer are sent back to their villages where they're ostracized, left because it's a smelly, unpleasant cancer, and no one gives them any help whatsoever. It becomes extremely painful later on too. The other treatments that we have are just not available, full stop. So the more we can do at the beginning end, the better. Now, vaccine is available through the GAVI Alliance in developing countries, and sometimes it works, sometimes it doesn't. India, it's not working that well because they haven't got systems in place that are good enough. Rwanda, with its non-democratic government and a bit of coercion perhaps, has done very well. Malawi has just started this year. Second dose has just been given last month. But look, 9,000, no, it's not even 9,000, 7,000 girls. It's a drop in the ocean. And what is coming out of these programs, these demonstration projects, are that they can invest in the infrastructure for a year, they can't maintain it. And doing it in schools is not as easy as it is in schools in Scotland. So we shall see, and we hope we will get involved in vaccine work as well in Malawi. So all you can do, in the absence of vaccine and not very good screening, is to try and limit HPV infection. And there's the level of messages that are given. Limit your number of partners, delay sexual debut. That's very difficult in many African cultures. Male circumcision is being promoted because their populations with male circumcision do seem to have less transmission. Avoid some of the abrasions that come with the traditional health methods when they go to traditional healers. Condom use is being promoted, but it certainly isn't foolproof for HPV infection. And to remember that actually persistence of infection in those with HIV is much more common. So what we really want more than anything else is to make the VIA available to all eligible women, not just in the hospital, but in the villages, and provide treatment. Actually, not by cryotherapy, but by different treatments, which I'll come to, and I've mentioned the HPV. So cryotherapy, at the moment, this is what's being recommended, not just in Malawi, but in most of Africa, is using a liquid gas, CO2, or if you can get it, liquid nitrogen. Most unlikely that you can get it because you can't really even get the CO2 easily. And it's fiendishly expensive. Every cylinder costs something like 400,000 Malawian kwachas, which is about £100. But the kwacha's going down significantly at the moment, so the cost and the availability is going up. And we've found, even in our short period, that Nkoma has had to provide some of the gas for government training of VIA. So generally not available. As a consequence, what happens is that people don't come for screening. They don't know about it anyway, and it's used as a diagnostic tool instead of for screening to diagnose those advanced cancers, which they don't then know what to do with. So instead, we've taken an idea which, of course, has been used in different parts of the world and was largely used in Dundee, cold coagulation, which actually is not cold but hot. It destroys abnormal cells by using a probe which is just touched to the edge of the cervix and destroys the cells at about 120 degrees. It's a very small, portable instrument. You can see it sitting in your hand. It needs electricity, but most places do have intermittent electricity. There's a bit of a capital outlay, a few £1,000s in our terms, but almost no running costs. And an interesting thing culturally is it probably likely that in the healing process is shorter, so the advice about abstention from sexual activity can be shorter. So these are huge advantages. And what we've gone with, therefore, is cold coagulation, not cryotherapy. And just to give you an idea with the VIA, there's a normal cervix. There's some aceto white around here. There's a large lesion down here, which is not suitable for treatment. And here's an overt advanced cancer. They all look very different, and those are extremes, of course, but just to give you an idea that what they're looking for to send women away with reassurance is the healthy cervix. So here we've got Hilary and Hilary Brown training Harriet in the use of a probe, the probe for the cold coagulation. And here's Harriet doing it herself. She's now very, very skilled in doing both assessing the VIA and in treating. So much so that the clinic started on the 17th of October. It's not that long ago. And the first 6 weeks we saw 542 women, which is an amazing number. The sensitization has been incredibly effective in the areas we've tackled so far. 60 VIA positives, 11%, lower than we thought actually. That's great. That does mean that these other women can be reassured. 32 treated, more than half of them by the Malawian staff who've now been trained. There's the sad bit. 17 cancers, advanced cancers, in that short time. And that was a matter of telling women who had been round the houses that there was nothing that could be done for them. Because they're not told that. No one will give them the bad news. There are 3 of the clinical officers, and Harriet's a nurse actually, and they've performed more than 50%. They're even beginning to learn colposcopy of difficult cases. Because the other thing we've introduced is the project funded a digital colposcope. There is no other one in Malawi at this stage. It will provide greater magnification, so it's useful for difficult cases. But unlike the use of colposcopy here, there is no way that this can replace VIA. A, there won't be the skill level, but B, it would take far too long. Rather, we want to use this as a teaching resource to have the digital image, to build up the digital library that can be used for training. Because one of the things that we found was really interesting. They had an A3 sheet of images, And all the Malawians who were doing any VIA could actually tell you correctly what the images were on that sheet. But they couldn't tell you when they saw a real cervix. So by having live digitized images which are constantly being changed and fired at them, they're all now doing self-assessment, the kind of standards that we would expect in clinical training and assessment. But we're also, as I mentioned earlier, trying to look at whether we can use HPV for triage. And there really are only 2 HPV tests that are suitable for low-resourced countries. The CARE HPV is a modification of what we use quite a lot, hybrid capture, here. And it's been used quite a lot in research studies, but it just isn't being made available anywhere. So, although it's from QIAGEN, you can't get it. Cepheid, however, have got into the market for TB in developing countries. And the cellular sample goes into a little cartridge. And the cartridge goes into the box. And it takes just about an hour to get a result out. So you can do small numbers, you can add them at any time. It doesn't take a huge amount of technical skill. It certainly needs a good power breaker. You don't, if the power changes, if there's a surge, it will cause a problem. But that's about all. And you get really good results. This top one was where the results can be HPV 16, 18, or high-risk others as a group. And the top one is one which was an other. The VIA was positive, and the woman was treated. The bottom one is someone who's got several HPV types, actually 16, 18, and other. So a lot of different HPV types, and the VIA showed advanced cancer. Sadly, we only had 50 tests when I was there in October. We've now had 120 delivered, not used them yet, but we haven't got into a cycle yet of getting HPV tests because this is so new. This is an Australian volunteer in the lab, who's actually the lab manager, who is at the moment carrying out the tests together with one of the Malawian people, but we will train several of the Malawian lab staff. Just 2 minutes to finish off with. That's all about cervical cancer. But HPV infection has a much wider burden. And this diagram, this pyramid if you like, shows the pink for the women but the blue for the men. So let's not forget that actually HPV is not an innocuous skin virus as we thought it was in the 60s, but something that is causing increasing cancers. Anal cancer, for instance, increasing in both men and women. Oropharyngeal cancers, particularly the tonsillar area, possibly partly related to changes in sexual practices, but there may be more than that. In fact, in Scotland, the tonsillar carcinomas are about the fastest growing, although they're small numbers, numerical base, it's the fastest growing cancer type in Scotland. And the interesting thing is we seem to knock out most of the other HPV types. Nearly all of these other ones are associated with 16, so 95% of them. A few with other types, particularly 18. So, for instance, if you look, this data here are Scottish cases, so they're small numbers. The numbers worldwide, the percentage worldwide caused by HPV, you can see that actually there has to be other kinds of cancers if you're only getting 40 to 50% or 3%. I think that figure needs to be updated. The oropharynx, sometimes we need to separate those out. Will vaccine help with this? Well, the interesting thing is looking at the early data. Australia introduced Gardasil, And what they found, first of all, was looking at genital warts, because the beauty about Gardasil is because it protects against type 6 and 11 as well as 16 and 18, is you've got a much more immediate marker of infection. And what they found was that there was a reduction in genital warts in the women who'd been vaccinated. Fine, you might expect that. But there was also a reduction in men of the same age group, without there being a reduction in older men or men who had sex with men. So in other words, there was a little bit of the beginning of herd immunity, which of course is what one would like on a big scale with any programmatic vaccine coverage. But what about Malawi and other developing countries? If they can't even deal with cervical cancer, there's no way they're going to be looking at any others at the moment. So let's tackle what we can. So Scotland is leading the world in many aspects of dealing with HPV infection. We've got really robust cervical screening. We've got sustained high uptake of vaccine. We are considering, at least it's being discussed, gender-neutral immunisation. And we have both excellent and adequate clinical skills to provide care when disease is detected. Whereas Malawi has huge educational needs at the government, healthcare professional and public levels, few options for screening, poor access to treatment, few options for cancer treatment, and no access to vaccine. Complete contrast. I think, as a consequence, that we have a duty to share our level of expertise and management systems with other countries, such as Malawi, to ensure that cervical cancer, and as a consequence, the other HPV cancers are no longer major killers. So in Scotland, we have, through our Scottish HPV Investigators Network, what we are really calling a cervical cancer prevention programme, with huge interactions between research and service. And that's it. Thank you.